Welcome to our video on HIV and AIDS. Let's get started. In this lecture, we will discuss HIV as a virus itself and HIV infection with all its stages, HIV post-exposure prophylaxis, HIV management during pregnancy, and the AIDS-defining conditions. Specifically, we'll discuss all the way from definition down to diagnosis and management. Let's start by describing HIV as a virus. Human immunodeficiency virus, also called HIV, belongs to the retrovirus family. All retroviruses, including HIV, are characterized by diploid genomes. In other words, they contain two RNA strands. HIV has several important proteins, the significance of which we'll discuss in the next few slides. But before explaining why they're significant, let's just discuss these proteins. Okay, so we've got the HIV envelope contains glycoprotein 120 and glycoprotein 41, and those are the glycoproteins necessary for viral attachment. Inside an envelope, there is a matrix composed of the P17 protein. The HIV capsid, on the other hand, contains the P24 protein. Additionally, there are three important enzymes for HIV replication. These are reverse transcriptase, integrase, and protease. Here we see a structure of HIV, and there is glycoprotein 120 and glycoprotein 41, and these are within the viral envelope. Under the envelope, there is a matrix composed of the P17 protein. The conical capsid of HIV is built with the P24 protein. Finally, there are two RNA molecules, and there's reverse transcriptase and integrase below the capsid. In order to talk about how HIV causes disease, we should discuss its replicative cycle. On the next slide, we'll discuss the replication steps listed here. So you can come back to these in your textbook for reference, but we'll describe these points visually on the next slide. Here is a visual representation of the HIV replication cycle. Knowing different points in this cycle is important to understand how different antiretroviral medications will work. First, glycoprotein 120 on the HIV envelope attaches to two proteins on the target cell membrane, the receptor and the co-receptor. The receptor is always CD4, while the co-receptor is either CCR on macrophages or the CXCR4 on T helper cells. Now, patients with heterozygous CCR5 mutations have a prolonged course of HIV, while those with homozygous CCR5 mutations are immune to HIV infection. Now, after attachment and fusion via glycoprotein 41, the HIV RNA gets transcribed by reverse transcriptase into double-stranded DNA. The double-stranded DNA then gets integrated into the host cell genome by HIV integrase. The transcription of double-stranded DNA results in mRNA, which then gets translated into various HIV proteins. These proteins are cleaved by HIV protease into their functional parts. Finally, mature HIV virions leave the host cell via budding from the plasma membrane. Homozygous mutation in which gene protects the patient from HIV acquisition? Okay, well, as we explained on one of the previous slides, a homozygous mutation in CCR5 will actually protect the patient from HIV acquisition. The HIV never gets inside the cell. HIV is a sexually transmitted infection. Therefore, unprotected sexual intercourse or presence of multiple sexual partners are risk factors, and men having sex with men are at especially high risk for HIV acquisition. Now, contraceptive methods other than barrier contraception do not decrease the risk of HIV transmission. Additionally, injection drug use and accidental needle stick injuries are known to cause HIV transmission. Finally, exposure of mucous membranes or broken skin to high-risk fluids such as blood, semen, and vaginal secretions is a significant risk factor for HIV. An HIV infection is characterized by 5 stages. Let's discuss one at a time. The window period, also called an incubation period, is the time between HIV acquisition and the onset of acute symptoms. And during this window period, the patient is asymptomatic and the HIV virus replicates at a high rate. After the window period, the patient experiences an acute retroviral syndrome characterized by mononucleosis-like symptoms such as fever, chills, fatigue, generalized lymphadenopathy, hepatosplenomegaly, and pharyngitis. Now, once the acute retroviral syndrome resolves, the period of clinical latency begins. During this period, the patient is asymptomatic. However, the virus continues replication in the lymph nodes. That is, the plasma concentration of HIV RNA reaches a significant amount, the patient starts experiencing skin and mucosal infections, such as oral thrush. Finally, once the CD4 positive cell count drops below 200, the patient is said to have AIDS, or acquired immunodeficiency syndrome, which is the last stage of HIV. Now, AIDS is characterized by an AIDS-defining condition, and we'll discuss those later. If HIV is suspected, the patient should be screened with an HIV 1/2 antigen antibody immunoassay, which looks for the P24 capsid antigen and anti-glycoprotein 120 antibody in the patient's plasma. If this test is positive, then we should confirm HIV with an HIV 1/2 antibody differentiation immunoassay, which differentiates antibodies towards the HIV 1 and HIV 2 virus. So let's say that the patient had positive screening test but negative confirmatory tests. Then what should we do? Well, in this case, we proceed with HIV 1 nucleic acid test, or NAT, which detects the HIV 1 RNA. If this is positive, then the patient is diagnosed with an HIV 1 infection. If it's negative, then the patient does not have HIV infection at all. Let's also discuss several specific circumstances. What if the patient is diagnosed with HIV and now we need to choose appropriate therapy? Then we need HIV genotyping to see if the patient's serotype is resistant to any of the commonly used antiretroviral medications. To monitor the effectiveness of the chosen therapy, we need to periodically review the HIV viral load currently in the patient's plasma. Now, to diagnose neonates of HIV-positive mothers with acute HIV infections, we cannot use the HIV 1/2 antigen antibody immunoassay because maternal IgG crosses the placenta and it might give false positive results in the newborn. Instead, we'll check the HIV viral load in the neonate. HIV treatment is also called highly active antiretroviral therapy, or HAART. HAART consists of 3 drugs. 2 of them are nucleoside reverse transcriptase inhibitors, NRTIs, while the third one is preferably an integrase inhibitor, but it can also be a protease inhibitor or a non-nucleoside reverse transcriptase inhibitor, NNRTI. Now, all classes of antiretroviral therapy are potentially effective for HIV-1. However, NNRTIs and enfuvirtide are ineffective against HIV-2. Understanding the potential toxicity is important when managing HIV or AIDS patients, due to how complicated they can become when balancing what they are at risk for based on the disease, but then also the treatment. So here are some of the unique side effects. And I want you to know that if you review our pharmacology image mnemonics, then you can help memorize all of these facts I'm about to tell you. Now, for NNRTIs, important side effects are rash and hepatotoxicity, and CNS symptoms, which are actually unique to efavirenz specifically. Protease inhibitors toxicity can lead to hyperglycemia and hyperlipidemia, GI intolerance, and lipodystrophy. And integrase inhibitors can lead to insomnia, dizziness, and increased CK levels, creatine kinase. So let's next discuss HIV post-exposure prophylaxis now. So in order to decide whether the exposed person needs prophylaxis or not, we need to figure out whether there was a high-risk contact or a low-risk contact. Now, high-risk contact requires PEP, while a low-risk does not. And a high-risk contact is defined as exposure of mucous membranes or broken skin to semen, vaginal secretions, or blood from an HIV-positive individual. Now, low-risk contact is defined as exposure to urine, saliva, sweat, tears, or nasal secretions of an HIV-positive individual. And we should start PEP as soon as possible and continue the drug regimen for 28 days. Now, preferred medications for PEP are 2 NRTIs plus 1 integrase inhibitor, a protease inhibitor, or an NNRTI. So, very similar to HAART therapy. Now we'll talk about HIV management during pregnancy. HIV management during pregnancy is very high yield for step 2. Let's start by discussing antepartum HIV management. HIV-positive pregnant women should start HAART as soon as possible, and we should check the maternal HIV viral load at the initial visit then 2 to 4 weeks after starting HAART, then every month until the viral load is undetectable, and finally, every 3 months. And CD4 positive cell count should be monitored every 3 to 6 months. And we should avoid amniocentesis unless the HIV viral load in the mother is less than 1,000. Now let's move on to intrapartum HIV management. First, we should avoid fetal scalp electrodes, operative vaginal delivery, or artificial rupture of membranes, ROM, because any additional surgical manipulation can introduce maternal blood into the fetus and cause HIV transmission. Now, the mode of delivery and maternal drug regimen depends on the maternal HIV viral load at the time of delivery. Now, if the viral load is less than 1,000, then we continue the antiretroviral therapy administration to the mother, and we perform vaginal delivery because the risk of HIV transmission is quite low at that level of viral load. In contrast, if viral load is greater than 1,000, then we actually continue the therapy and keep administering that to the mother, and you also add zidovudine on top of it. Additionally, we perform a cesarean delivery to minimize HIV transmission to the fetus. Finally, let's talk about postpartum HIV management. After delivery, we continue the antiretroviral therapy in the mother. As for the newborn, the treatment depends on the maternal viral load. If maternal viral load was less than 1,000 copies at the time of delivery, then we should give only zidovudine to the infant, because the risk of HIV transmission at this level of viral load is low. However, if maternal viral load was greater than 1,000 copies at the time of delivery, then we should give multi-drug antiretroviral therapy. So again, 2 NRTIs and 1 other antiretroviral medication. Now we'll move on to discuss AIDS-defining conditions. Mycobacterium avium complex, MAC, or Mycobacterium avium intracellular, is common in HIV-positive patients with CD4 counts less than 50. Now this MAC, or MAC, is an acid-fast bacillus just like all of the other mycobacteria. And MAC causes non-specific symptoms such as fever, weight loss, night sweats, or focal lymphadenitis. Although azithromycin used to be administered for MAC prophylaxis to patients with CD4 counts less than 50, this is no longer recommended because a MAC infection is rare. However, if you're treating an infection, then azithromycin and ethambutol can be used, and you can actually potentially add rifampin. Let's move on to Toxoplasma gondii. Toxoplasma gondii is a CNS protozoan acquired most commonly through undercooked pork and sometimes by exposure to cat feces. Toxoplasma infection is common in HIV-positive patients with a CD4 count less than 100. It causes brain abscesses, which look like ring-enhancing lesions on a brain MRI. And prophylaxis for toxoplasma is with Bactrim, TMP-SMX, or trimethoprim sulfamethoxazole. And that actually starts when the CD4 positive cell count is less than 100. So that's prophylaxis. Now, treatment for Toxoplasma gondii is pyrimethamine and sulfadiazine. Here's a ring-enhancing lesion on a brain MRI consistent with the Toxoplasma brain abscess. How can we distinguish Toxoplasma brain abscesses and primary CNS lymphoma on a brain MRI? Okay, let's remind ourselves that although both of these conditions look like a ring-enhancing lesion on a brain MRI, Toxoplasma abscesses are usually multiple, while a primary CNS lymphoma is mostly a single lesion. Now we move on to Candida esophagitis. This infection is common in patients with a CD4 cell count less than 100. Candida esophagitis, just like any other causes of esophagitis, causes dysphagia, so difficulty swallowing, and odynophagia, or painful swallowing. Endoscopy will reveal white plaques similar to those of oral thrush. Microscopy will show typical yeast and pseudohyphae. Now, treatment for Candida esophagitis is nystatin, fluconazole, or echinocandins. Here we see multiple white plaques on the esophageal mucosa characteristic of Candida esophagitis. Let's discuss Pneumocystis jirovecii. Pneumocystis jirovecii is a fungus, which usually causes interstitial pneumonia with ground glass opacities on a chest X-ray. Now, you actually diagnose it by obtaining some lung tissue via a bronchoalveolar lavage, or BAL. And microscopy shows disc-shaped yeast on Gomerai methanamine silver, or GMS. Now, prophylaxis for pneumocystis pneumonia, we sometimes call that PCP, starts with Bactrim, TMP-SMX, when the CD4 positive cell count is below 200. And first-line treatment, so again, we're moving from prophylaxis to treatment, is Bactrim. So, the same thing. However, if a patient has a sulfa allergy, then alternative medications are trimethoprim dapsone, atovaquone, or pentamidine. Here's an image showing the disc-shaped yeast on GMS-stained lung tissue. Here we see a normal chest X-ray on the left, and on the right, we see ground glass opacities, which is consistent with pneumocystis pneumonia. Now we will move on to discussion of CMV retinitis. Cytomegalovirus, CMV, is a herpes virus transmitted via blood, saliva, sexual contact, transplants, or urine. CMV retinitis is painless, and it is characterized by perivascular exudates on fundoscopy exam of the retina. This is in contrast to HSV retinitis, which is also common in HIV-positive patients, and it's painful rather than painless. A first-line treatment for CMV retinitis is either ganciclovir or valganciclovir, and second-line treatment for ganciclovir-resistant CMV is either foscarnet or cidofovir. Here we have an image of a fundoscopic retinal exam of an HIV-positive patient showing perivascular exudates, and this is most consistent with CMV retinitis. Let's now talk about Kaposi sarcoma. Kaposi sarcoma is caused by a sexually transmitted virus called human herpes virus 8, HHV8, and it's common in patients with a CD4 positive count less than 500. Biopsy shows lymphocytic infiltrate because HHV8 is a virus, so you're going to get the lymphocytic infiltrate instead of neutrophilic infiltrate. In contrast to that, a biopsy of bacillary angiomatosis shows neutrophilic infiltrate because that infection is caused by a bacteria called Bartonella hensleyi. Now, treatment for Kaposi sarcoma is initiation of combined antiretroviral therapy. Additionally, if there's a local lesion, we can use intralesional chemotherapy like vinblastine. On the other hand, if there are diffuse lesions, we should use systemic chemotherapy such as liposomal doxorubicin. This is a classic appearance of Kaposi sarcoma with dark red, purplish papules and plaques, representing vascular malignancies. What are two distinguishing features of Kaposi sarcoma and bacillary angiomatosis? Okay, now two distinguishing features of these two are, first, Kaposi sarcoma has lymphocytic infiltrate. However, the biopsy of bacillary angiomatosis has neutrophilic infiltrate. Okay, so that's the first distinguishing feature. Second, Kaposi sarcoma is present in moderately immunosuppressed patients with CD4 counts less than 500. While bacillary angiomatosis is usually present in severely immunosuppressed patients with a CD4 count less than 100. Now let's wrap up with a board-style question. A 26-year-old male comes to the physician due to recent onset of fatigue and sore throat. He does not have a history of recent travel or exposure to sick contacts. The patient has sex with both women and men with irregular use of condoms. The vital signs include a temperature of 38 degrees Celsius, a blood pressure of 120/75, and a heart rate of 87 beats per minute, and a respiratory rate of 17 breaths per minute. Physical exam shows exudative pharyngitis, diffuse cervical and inguinal lymphadenopathy, hepatosplenomegaly, and diffuse macular rash sparing palms and soles. EBV and CMV antibodies are negative. HIV 1/2 antigen and antibody immunoassay comes back positive. However, the HIV 1/2 antibody differentiation assay is negative. Which of the following is the best next step in management of this patient? A. Repeat the HIV 1/2 antibody differentiation immunoassay. B. HIV nucleic acid test. C. Measurement of HIV viral load. Or D. Reassure the patient. Okay. This question is focused on the diagnostic algorithm of an HIV infection. So this patient's symptoms, such as fever, exudative pharyngitis, diffuse cervical and inguinal lymphadenopathy, hepatosplenomegaly, and diffuse macular rash are consistent with acute retroviral syndrome. Additionally, this patient has positive HIV 1/2 antigen antibody immunoassay, but negative HIV 1/2 antibody differentiation assay. At this point, we cannot definitively diagnose him with HIV. We first need to perform an HIV nucleic acid test. If HIV nucleic acid testing is positive, then this patient truly has an HIV infection. If the HIV nucleic acid test is negative, then he does not have an HIV infection at all. Therefore, the correct answer in this question is option B, HIV nucleic acid test. Let's discuss why the other options are incorrect. Option A is incorrect because repeating HIV 1/2 antibody differentiation immunoassay is not needed in case of initial negative test result. So you don't just repeat that test if you just got a negative one just previously. Now, option C is incorrect because measurement of HIV viral load is usually performed after an HIV infection is definitively diagnosed to establish the patient's baseline viral load and then monitor results of therapy. In other words, you measure HIV viral load after you already know that they have HIV. Now, option D is incorrect because it's premature to reassure the patient. First, you need to investigate whether his positive screening test result was a true positive or not. So, the correct answer is B. Do an HIV nucleic acid test. And that concludes our lecture on HIV and AIDS.